We had a new person start today, and they're outside my office being greeted, and they're all excited. And I don't know if you heard any of the background noise. So anyway, sorry about that. So we're coming to these different groups with some really short overviews on the relationship of oral health to overall wellness, and specifically for this group, the role of periodontal disease and its role in pulmonary disease. And I've been active in this area probably for about 15 years now. It started when I was working at the Colgate-Palmolive company as the global director of scientific affairs, and this was a big area for the company relative to improving oral health and trying to have an impact on overall wellness. And I've kind of carried that forward since I've been at WVU since August of 2018. So to start with, I think it would be good just to give you a frame of reference relative to the periodontal tissue. So when you think about the periodontal tissues, this is the supporting structure of the teeth in the oral cavity. The teeth reside in either the maxilla or the mandible in a socket. However, there is a ligament that in a sense connects the root of the tooth to the bone, forming sort of a hammock. And that's why you have proprioception and you have sensation to pressure and other things when you're chewing. And this is covered by the soft tissue, which is the gingiva. And the gingiva forms a very, very shallow pocket between the tooth and the soft tissue. This cuff around the tooth is called the periodontal pocket. And normally it's between 1 and 3 millimeters in depth. If it starts to get deeper than that, it can be either due to one of two things. Either you're starting to lose connective tissue at the base of the pocket, which is periodontal disease as it's advancing, or the tissue is swollen, so you have what's called a pseudopocket. So even though the attachment level where the ligaments attached to the root are not affected, the pocket seems bigger. So periodontitis or periodontal disease is an infectious disease. It's caused by the plaque or biofilm that forms on the teeth. Normally, you keep that under control by brushing your teeth twice a day, mechanically removing the biofilm, and hopefully preventing any sort of an inflammatory response. However, we know that not everyone does a great job cleaning their teeth all the time, and you could end up with an immunoinflammatory response, especially in a susceptible host. Again, the amount of plaque that's on the tooth may not correlate directly with the amount of inflammation that's present, and that really brings into account the host response. If this is left unabated and unchecked, it can progress to the point where you start to lose connective tissue and bone. The metabolic balance between maintenance, resorption, and formation get out of whack, and you start to see a net loss of tissue. And eventually the pockets will form. The bone loss will become so severe that the tooth may not be supported anymore, and that's when the tooth has to be extracted, unfortunately. The progression of this process is really based on risk factors for each individual. So there might be environmental risk factors such as smoking, for example, acquired risk factors such as diabetes, and genetic risk factors. It could be that from a hereditary standpoint, you may not possess certain genetic phenotypes that allow you to, say, resist the infectious burden. So as I mentioned, the earliest stage of periodontal disease is called gingivitis. This is totally reversible. This is where the bacteria start to form a biofilm in the pocket. It isn't mechanically removed, and the tissue responds with an inflammation. If you go in and you clean the area effectively by mechanically removing it with a toothbrush or using anything that's over the counter that has an antimicrobial effect, whether it's a toothpaste or a mouth rinse, you can quickly reverse this back to a healthy situation. Additionally, a hygienist or a dentist who performs a dental prophylaxis can help you get to this stage as well. The challenge becomes when that early inflammation starts to become more serious. And I apologize first thing in the morning showing you some pretty gross pictures, but this is kind of what we see very often in our patients. You may be seeing some of this in your patients. And again, early periodontitis, there's some loss of tooth support, but this can be treated and the progression can be halted. You normally don't grow back the bone and the connective tissue that you've lost, unfortunately. There are some surgical procedures where you can do some grafting of both hard and soft tissue to the areas that are severe and hopefully regain some of that support. But for the most part, you stabilize the patient and hopefully they don't progress any further. There are a small number of individuals who continue to advance where they start to lose quite a bit of tooth support, and that's where, as I mentioned earlier, they will lose a tooth or teeth due to the disease. The real challenge is this disease is painless. You would think something like this would hurt, but it actually doesn't. And most individuals may see some bleeding gums. They may not, depending on the extent of the inflammation and the location of the inflammation. But they really notice it either when they develop an abscess and then it becomes painful because of the pocket and the biofilm that's in the pocket, or the tooth becomes mobile and they report that the tooth is loose and they don't know what's going on. And again, by then the damage is so severe that really the only option is to remove the affected tooth or teeth. So if you think about this as a process, you have the bacteria, they form a biofilm that can develop into gingivitis, but it's a reversible process, so it sort of can sit in this area. There are inflammatory reactions, both were in gingivitis and periodontitis, and these inflammatory reactions are important as we talk a little bit later relative to the specifics on pulmonary disease. There are a number of risk factors that can take someone who has gingivitis and move them into active periodontal disease or periodontitis. Diabetes is strongly associated with that. Smoking, poor oral hygiene. Men seem to be have a higher risk than women. In individuals from a lower socioeconomic status, primarily due to access to care issues, will also see this progression. There are dental defects that we talked about. You can have tooth mobility and abscess as well as tooth loss. However, there are associated medical conditions that have been identified in the literature over the last 30 years that are related to periodontitis. And the strength of these relationships vary depending on which one you're looking at and the level of evidence. There is no one today that says if you have periodontitis, you will develop, say, diabetes. However, if you're diabetic and you have periodontal disease, it is known that the periodontitis can affect the ability of the patient to manage their diabetes and manage their blood glucose level. In reverse, someone who has diabetes is more susceptible to periodontal disease because of all of the metabolic aberrations that happen due to the high blood glucose level, HbA1c being elevated, etc. So we're going to focus obviously on respiratory disease, but this is just a summary showing you some of the various diseases that have been associated with periodontal disease. Today, for the next couple of minutes, we're going to focus on pulmonary disease. So when we think about oral health and pulmonary disease, there have been clinical associations made between the periodontal disease and the bacteria that cause periodontal disease and the lower respiratory diseases, specifically nosocomial pneumonia and COPD. And what they've demonstrated is that you either if you intervene or you prevent the ability of the bacteria from the mouth from colonizing the pulmonary system, you can actually prevent this quite effectively. I'll give you the punchline right now. It just really comes down to good oral hygiene for these individuals, especially those that are either intubated or they're in, say, an assisted care facility where they need someone to help them, keep their oral hygiene in a stable situation. So what are the potential mechanisms or the modes of action that something from the mouth, bacteria from the mouth, can actually affect the pulmonary system? Well, the first is a direct infection. You have respiratory pathogens that may be colonizing the dental plaque. We know that those pathogens are in the oral cavity. The individual can aspirate them, or they can be introduced through intubation, and an infection can ensue in the pulmonary system. The second is that the oral bacteria themselves, so bacteria that are causing oral disease, are aspirated into the lower airway in a similar mechanism, and they can actually modify the local environment. They can actually have an effect on the soft tissue and actually create a more desirable environment for a respiratory pathogen now to come in and affect the respiratory system. And then last, but certainly not least, because the periodontal disease is an inflammatory disease, we know that there are cytokines and other pro-inflammatory proteins that are produced by the soft tissue and the hard tissue as well in response to the infection. These can be aspirated as well into the oral through the oral cavity into the pulmonary system. It can also have an effect on the local environment within the soft tissues, again, increasing the risk for infection by respiratory pathogens. So usually when someone develops something like this and it's respiratory disease and it's tied back to their oral cavity and the lack of good oral hygiene, which one of these actually caused it is not known. All we know is what the end result is. But just to give you, just the ideas of some potential mechanisms. So even though this is from 2007, which seems like ancient history for some of us on the call, this is a really nice diagram describing exactly what I just talked about on the previous slide, where you have bacteria and inflammatory mediators that can enter into the lungs and have those effects that we mentioned a moment ago. The same thing with intubation. You can actually see a colonization of a person who is chronically intubated, a biofilm forming. It's no different than someone who has an indwelling catheter or any other intubation into the body. Biofilms can form on these devices, and those biofilms could be transported down into the lower airway, where again you can get an infection. So what do we do to manage this? Well, especially if someone is coming into a hospital situation where they're going to be admitted and they may be intubated, especially in an ICU situation. I had an experience with my sister who developed Guillain-Barré back in 2007, 2008, and she was intubated for about 8 weeks while they were trying to remove all the antibodies from her system, so that her myelin can start to redevelop and she could develop some movement. And this was one of the first things I asked the nursing staff after she was admitted into the ICU is, what is your oral hygiene regimen? And they had a very robust system where they would go in and do a clinical exam every day, an oral exam, and then they would try to clean her oral tissues, usually with a sponge in some sort of an antimicrobial agent to try to keep the plaque bacteria from developing and colonizing the respiratory device. Sometimes you can brush the teeth and floss them. Sometimes you can if they're intubated. But if they aren't, you can do that. You can rinse all the oral surfaces with an antimicrobial rinse like Listerine. Colgate has one. It can just be something over the counter. Peridex can be used as well, which is prescription strength chlorhexidine. If the person is obviously non-responsive, you want to remove the secretions as needed, especially if the patient is intubated. If they have hard deposits on the teeth, if possible, to remove those. That's the tartar that we're all familiar with that the hygienist has to remove when we go in for our recall evaluations. This would require someone with dental training, and if you have a hospital with a dental service, this would be an ideal step to take. But if you don't have someone on staff, you may have to look at bringing someone from outside to help you with this step. And then if there's an elective procedure, part of the pre-admissions process should be to have their teeth professionally cleaned, as well as taking care of any teeth that may have active disease so that these don't crop up later and cause a problem as the person is trying to deal with their medical condition. As far as any patients that are ventilated, and we've had many of those over the last year, unfortunately, putting the patient's head to the side can help in reducing the risk of colonization by respiratory pathogens. The deep suction, again, brushing the teeth with a wet, soft toothbrush. It doesn't have to have any paste or anything on it. Just the mechanical removal of the plaque is really ideal. Treating the oral surfaces, again, with an antimicrobial rinse. And then, as I'm sure you do, you apply some sort of moisturizer, not only on the lips, but also in the oral cavity, because it can get dried out. And sometimes that dry environment actually promotes the plaque for development. Saliva is, along with a lot of other things it does in the oral cavity, it does have an antibacterial component. And so if the mouth gets dry and the saliva is reduced, this could also enhance the buildup of the plaque around the teeth. There's a lot more I could talk about, but I was told, to try to keep this to about 20 minutes or so. So in case there are any questions, I would love to come back at some point and talk a little bit more about the role of smoking on periodontal tissues, because I think that is an important area that we could discuss. I'm sure a lot of your patients have smoking as one of their habits. The emergence of e-cigarettes and vaping. There's a lot of research right now on its role in oral health, so we could drill down into that a little bit. And then there has been some emerging evidence around COVID-19 and its effects on the periodontal tissues, as well as for those patients who have dental implants, the effect on the hard and soft tissue of these implants. So a lot of emerging research in all of these areas that I think might be of interest in the future. And as I said at the beginning, this is part of a process that we're hoping to continue with all of the ECHO groups that we're working with, that we can bring a little bit of oral health to the group and hopefully help you manage your patients. And so with that, I will close with this one very simple, but I think supported statement that the evidence strongly supports this association, especially through the intervention and prevention that I talked about. That's the best way to prevent this from happening in your patients. So with that, I will finish up and I will exit from this, and I am happy to answer any questions that anyone has.
Well, first and foremost, thank you so much, Dr. Panagakos. We would love to have you back as well, talking about the role of e-cigarettes and the COVID article that you also referenced. That would be incredible. And
Yeah.
this was just such an important didactic, and we truly appreciate you taking the time to go over all of that and how much correlation there really is with, pulmonology and everything. So thank you.
And no, you're welcome. And I provided 2 PDF documents as well as these slides to Mithra. One is an article that was recently published, and it really just is a review of the relationships between periodontal disease and some of the other factors that we, other comorbidities, excuse me, that we talked about at the beginning. And the other is a chapter from a textbook, which is also, the entire book is available at colgateprofessional.com. It is the chapter on periodontal disease and respiratory disease. When I was at Colgate, we produced this textbook with a group of outside experts that really kind of summarized the research around oral health and systemic health. And this is the respiratory chapter that I think, even though it's a few years old now, I think most of the information there is still very relevant that you might find of interest. So are there any questions for me?
We got a chat in thanking you very much for the
Oh,
presentation.
you're welcome. You're welcome.
And absolutely, I'll be sure to include those other 2 PDFs in the recap email as well.
Sure.
Any questions or even comments, Dr. Werns?
Sure. Quick question. I'm going to stay away from the intensive care unit because that's a special case. But in the outpatient world, you did mention that how smoking can both affect dental. My understanding is that it can affect the oral flora, which is why we worry about its impact on children who are not smoking, but that are hanging out with smokers.
Right.
And obviously that connects with COPD as well. And so my question is there any evidence of a connection between oral health or periodontal disease and respiratory disease outside of COPD or a tobacco-based association?
Other than the infections that I spoke about, I don't believe there are any direct relationships in the literature. I tried to do a review as best as possible in preparing for this talk. Obviously, trying to keep it to a short time limit. I left a lot of details out, as you can imagine. I think the effects on the respiratory diseases other than COPD and the infectious diseases that I mentioned earlier in the talk are probably the bulk of where you see a direct relationship that you can kind of tie one to the other through a mode of action or the delivery of something from the mouth to the pulmonary system. The other conditions may be influenced by periodontal disease, but indirectly. So, for example, someone who has black lung, we know that that's due to, obviously, the working in the coal industry. If the person has diabetes as well, for example, that's going to impact their overall health. It's a metabolic disease. There's got to be some relationship between those, maybe not directly, but indirectly. It could affect the immune response. It could affect other things that the body is trying to mount in response to the diseases. The periodontal disease feeds into that. That's an inflammatory focus in the body. And so the idea is to try to remove that. So it probably is not as well described, but just like with any infection in the body, it's going to have an effect somewhere. And what's interesting is that if you were to measure the surface area of a person who has moderate periodontal disease on most of their teeth, and we have 32 teeth, let's assume they had their wisdom teeth taken out, so they have 28. The infection, the surface area of the infection would be about the size of the palm of your hand in the mouth. And you can imagine something like this elsewhere on the body, we would all be very concerned, right? Mm-hmm. But in the mouth, because it's all spread out and it's under the gums and you don't see it, it's not top of mind. But I think if you think about it in that regard, you can start to make those connections. Hopefully that answers your question, Dr. Mm-hmm. Werns.
Sure. Thank you very much.
You're welcome.
Any other comments or questions from the group? Feel free to chat in as well, and I can read it out for you guys. And Dr. Panagakos, I know you had that one slide emphasizing making sure to put like moisturizer on the lips and inside the mouth as well. Do you have any recommendations on what type of moisturizer? I know some people use like Vaseline or Aquaphor, but I wasn't sure if those might not be good.
As far as on the lips, any sort of lip balm, I'm sure that there's, people use, various things. In the oral cavity, there are products available over the counter. There's saliva replacement solutions. Biotene makes some. There's a few other companies. I'm trying to think of the names. I can't off the top of my head, but those are usually really good for people who have dry mouth, and it would just be applying it with like a sponge on a, one of those sponges on a stick. You dip it in, you can just really coat the inside of the mouth, and if it has a little bit of viscosity with it, it'll last a little bit longer versus something that is more watery, for example. So that's what I would recommend, just something over the counter. And some of the Biotene products actually have antimicrobials as well, so that could actually help in the process.
Great, thank you so much. Anyone else? And as always, if there are any questions or thoughts after the fact, just feel free to shoot me an email. I'll make sure to send them to Dr. Panagakos. Hopefully it's not a whole bunch of questions for you to have to answer.
Yeah, and if any of the other topics are of interest, please let Elizabeth and Mithra know, and we can work out another short session so I can cover one of those topics with you and continue the dialogue. And please use the School of Dentistry as a resource if you have any questions on anything orally related. We have all the specialties here, and we're all part of the same healthcare team trying to improve the quality of life of our patients. And we in the dental field want to do our part as well to partner with you to make that happen. So unless there's anything else, I guess I can leave. Or do you want me to stay? It's up to you. I can stay, or
that would be perfectly fine. Dr. Panagakos, just wanted to emphasize our gratitude for you to coming here and giving that talk today. And we're getting some chats as well, thanking you for the excellent.
Yeah, no, my pleasure. My pleasure. Have a good rest of the meeting. Thank you.
Thank you so much. Take care.
Okay.
All right. So I guess the only announcement that I do have is that our next session will be on April 19th, and Dr. Zulfikar will be discussing Introduction to Interventional Pulmonology. So keep an eye out for that reminder. And as always, have a great day, and we'll see you guys next time. Bye.
Bye. Thank you.